Thank you very much for inviting me to share something that's very, very important to me and close to my heart. I've been following up babies born preterm for over 18 years, and I've noticed how important the mother's presence to the outcome of the child's development. And that's why I'm sharing these slides with you. So one of the things that I remember as a registrar is thinking about the baby, but never looking beyond intensive care, and thinking that the baby's actually heart and lungs and brains, and how I can protect all these organs. And then when you start following babies up, you know that's not what makes a difference. I had babies who had no brain bleeds and had no insult, and they were late preterm and they did worse, and I noticed that mom has never been next to her baby. And babies who had grade 3 intraventricular hemorrhage, bleeds in the brain, and did much better. And I started feeling that this is going to be really significant. When a mom comes to the clinic, I can tell that it's going to be better because she was always next to her baby. So I went on and did some literature review, and there's hundreds of literature, and searching them I found that parental sensitivity and maternal education was one of the constant theme that's coming across that influenced the child development. And we went on as well to produce some guidelines through NICE, published in August 2017, if you are not aware about educational needs of children born preterm, developmental and educational. So that's not my slide, but thank you again. So sometimes when I speak to people who've never been on a neonatal unit, they think that babies who are preterm are just nice and cute and small babies. But the reality of it is they are babies who are under a lot of stress. And that's the reality. How can we make life better for them? And how can we think beyond intensive care? Because whether we like it or not, these babies are going to grow up. And we have to think about the future and not think of this is my bed. And one of the things that helped me is following some of the children up till school age, and even some of the ones I discharged thinking they are okay, come back to me at school age in one of the clinics I do outside the hospital and in the community. And you see their struggle and the parents' struggle. So it's very easy to focus in intensive care on the biomedical model. And it's easier to measure. So anemia, give blood, phototherapy for jaundice, but the psychosocial model takes more effort and difficulty to measure. But what makes you an individual is not just your biological part, but your social and psychological part. So I thought, how can we help the nurses to see that? Unfortunately, they are not coming to the clinics. They don't see the babies beyond discharge, or sometimes they come and they are walking and they are laughing and they think everything is okay. They don't know the subtlety of developmental problems and behavioral problems these children are having. I found that everything costs a lot of money. We know about the high noise level, lack of pleasant touch, lack of pleasant smell, all the intrusive light level, and lack of visual stimulation or overstimulation, and this baby's development is going to be affected, and their sense development is going to be affected whether we like it or not by the environment they are in, and it's going to impact on them. And everything was costing a lot of money, and we don't have money. We don't have 450 pounds to send people to NetCap, or I shouldn't mention names, but it's good programs, but cost a lot of money. But it's very good, and I was really longing to have all our neonatal staff going on things to assess baby's behavior. And then the Royal College of Pediatric and Child Health with the Royal College of Psychiatry and the Royal Society of Psychology came up with a program called Child in Mind, because they noticed that doctors don't get any training on the psychology of the children. And they started with stage 1 and 2, and then they came to stage 3, which is neonates, about the competency of the newborn and promoting positive relationship. You can access the material and deliver it for free. So I thought, no, I'm not going to give it only to ST1s to ST3, which the program was for. So I took a practice development nurse from our unit in Princess Royal, and we went to access the material. And it talks about the senses and about the behavior and how can we understand this. So we started doing it across Glasgow. We took it to Caledonia, to break the barriers and get them to understand why we are doing developmental care, why we do what we are doing to the nurse module, and now we do it to the neonatal nurse module in the west of Scotland, all nurse inductions in Glasgow, and through the family integrated care, both in Queen Elizabeth and Princess Royal, we are giving a modified parents talk. So trying to understand, because you can't just say to people, do this and do that, and don't explain why. So we talk about the baby's behavior as their language, and we have to understand the behavior. An example for that, we say that it's easier to understand the behavior of a term baby who is rooting, who is crying, who is arching his back, but sometimes the baby who's sick and the baby who is preterm can have a subtleness of these behaviors that you might miss. But their experience will be affected and their development, as I said, by their experience in the neonatal unit. So we have to look at them because they are talking to us. They are capable of utilizing their senses, because smell, for example, by 14 weeks, the chemoreceptors are already developing in the fluid around the baby that's specific for this pregnancy. So the mother's smell is specific for these babies, and they can be soothed by the smell of the mother. We use many booths for the babies in our unit, and the mother and the baby like it. So everyone heard about the many booths? And it can soothe the baby and stabilize the blood pressure and the oxygen level. Because do you know what? The first thing that is a sign of stress for the baby is their behavior. If you miss the behavior, it goes to physiological. So they start desaturating, the oxygen level changes, the blood pressure changes, the heart rate changes. And if you are not aware of this, eventually the stress hormones kick in, and it has detrimental effect also on the brain. So it's important that you understand these behaviors. Maybe have a preference to sweet taste, and we use sometimes mouthwash using mother's milk. It can soothe the baby. And they found as well in a Cochrane review that using a dummy, which is non-uterine sucking, can aid discharge and can help move from tube feeding to oral feeding. So it's very important that babies utilizing it, the smell and the taste. Hearing. Babies hear through their skeletal system from 16 weeks, but then you've got the organs of hearing is well developed by 24 weeks. And they know the sounds of the parents. They know the mother's voice, and then they develop a preference to the mother's voice, and then they will know the dad's voice. So it's very important they talk to the baby. You know, I remember I was introduced to developmental care when a neonatal nurse told me, I was in Queen Mother, I will never forget, I was a registrar leaning on an incubator, and she said, don't lean on an incubator. And I said, why? Because I'm all medical. I can intubate, and I can put lines in, and I can protect the baby's organs. But don't be shy to tell the doctor, because I wasn't aware till somebody told me. And they got the speech and language to speak to me, who was introducing developmental care. And I was changed, because you know, a sound like this inside an incubator, which is 5 seconds, can make a change in the heart rate for up to an hour. Do you know what is the British safety standard for noise inside an incubator is? Yeah, so it's 60, maximum 65 decibel. This is like 120, like a boombox, just tapping on the incubator or closing the doors of the incubator suddenly. So we have to be aware of all of this. Sight is important because babies from 32 weeks onward, they can develop part of their pathway and the lay down of part of their pathway during what we call rapid eye movement or light sleep. So we have to understand the baby's states of arousal, about the baby's sleep, and how the sight is important. And it's important as well because every baby has his focus point. So it's good to say to the mom, even at term, he can look at you if you have at this distance. Babies who are with us for longer is very good, although babies 6 weeks after their due date, they fix and follow, but they can fix briefly from a certain focus distance. So it's very important, and they have a preference to parents' faces. And I show the parents some videos to prove what I'm saying about the smell and about the sight. And just we have to remember as well that they cannot limit sometimes the light going through their eyes, even if their eyelids are closed, so it can be very intrusive to them. And touch is very important. And when you think about what people are exposed to, babies are exposed to when you are put in an incubator. When I went to the Royal College to access the material, somebody volunteered me to be in the hot seat. And that was really mind-opening, eye-opening for me, because I imagined myself one of the babies that was just in the unit. And how do I feel with the things around me? How I'm lying in this incubator, not knowing what's going to happen when somebody opened the door and touched me. To prick me, to put a cannula in, to put their cold hand in, to get their gel near my mouth and my face. And I can't say no. So I start not trusting the world around me. And it's so important to think, how do these babies feel? Put yourself, how do the family feel? I started seeing my 9-year-old sibling, when I imagined that baby, crying because he's terrified seeing his brother with all the machines around him. So I had to speak to him at the time to calm him down, to think about the family. So it's very, very important to know that they feel everything. When we started the neurodevelopmental clinic, babies will not put their feet sometimes on the floor because of the heel pricking. Now with positive touch, with developmental care, I don't see that. Babies were very aversive to feeding. I don't see that, very few. Mothers used to put the Hoover on to get the babies to sleep. I don't see that anymore. I had only one mom whose baby was on CPAP who said that she had to, for a long period, had to put the hair dryer on. But that's now the rare thing. It used to be the common thing when I started the developmental clinic. And I had a mom recently said that twin sleeps better than the other twin because he was longest in the neonatal unit. So this is a video taken by parents. It's an amateur video. And I show the parents and I say to them, imagine how does this baby feel and if you can see any signs of stress the baby has. How do you feel if I keep playing this video for you over and over again for 3 months? These babies are with us for a few months. And you can see the sign of stress. So these parents are loving parents. And we have to empower them and encourage them to see that the baby was looking away from them. They had their hand up, they started yawning. These are signs of stress. How would they know if we don't tell them? But be gentle. They are the parent. They are going through the worst time of their life. We also introduced pain. There is one of the neonatal nurses who did her PhD in pain. And she's producing some protocol, but we are doing pain score because pain actually affects baby's brain so much. And it affects the deep gray matter and it affects the white matter, the reduced fractional anisotropy, that's the maturity of the white matter. And they found that babies are exposed to about 16 procedures per day in a tertiary neonatal unit. It's not only that, now we know that we cannot separate stress response from pain response in some of these preterm babies, and it's the same effect. And they feel pain more because they don't have the dampness of the nerves coming down to reduce the effect of pain. And this pain is not actually stored in verbal memory, it's not formed yet, but in nonverbal. So behavior will be affected because of the pain. But even if they cannot say it verbally to us when they are older. So there is immediate adverse effects affecting the physiology of the baby with their breathing, and if it's in the critical period, it can cause bleed in the brain, but inability to self-regulate as well. And this is something we see a lot in children born preterm, they don't know how to organize themselves and calm themselves down. And you see this in preterm, for example, who refuse to take a dummy. They don't know how to organize themselves. So everything takes longer for them to calm than a normal child or a baby. Everything is just they don't know how to bring themselves back to calmness. So repetitive pain is not good for them. The only one who can counteract this is the mother's touch. And when you look at the long-term effect of prematurity, they are not just going home and they're sailing through, it affects their social life and education. I'm not going to go through all their problems with learning, but I'm giving you an example. It affects their cognitive profile. So a lot of these babies have normal cognitive profile, but low normal, especially if they are extreme preterm. And there is Scottish studies that showed prematurity has a linear correlation between how early you were and if you need additional support need. Attention, not hyperactivity, so it gets forgotten about because you just have attention difficulty but not disruptive. And emotional, they are very internalizing. They can go into depression in teenage years and they can be bullied. And they have visual problem, spatial problem, and processing speed and working memory problems that affect their education, but they are so subtle, and unfortunately education still are not aware of these subtle difficulties. Because part of the things that actually grows with you as you are doing your attachment is your limbic system. And as you see, that part of the limbic system is what connects your thalamus to your cortex, and what connects the two sides of the brain, which is the corpus callosum. But it affects your mood, affects your memory, and it affects your emotions. So a brain under stress, the part that will increase is the part that fear and flight. And the part that will reduce and atrophy is the part that deals with your memory and learning. And this is an old slide, which is a PET scan. The redness shows how active the brain is. The dark blue shows how inactive the brain is. And this taken from orphans from the Romanian orphanages during Ceausescu. And you can see that babies who are neglected, they have less active brain. When you think about 30 years ago in this country, and currently in some of the European or China, I heard some of the neonatal units are doing this, which is we are responsible for the baby, putting them in incubators and no touch. Their brain don't grow as well because they are ignored. Some of them go home and they rock themselves to sleep like orphans. We haven't built this relationship between the child and the mother. There is a lot of work. James Boardman, one of the professors of neonatology from Lothian, has been involved in showing how these babies at term, their brain is different from babies born at term. So if you are born preterm, your brain, functional brain at term is different from if you are born at term. So you can see why empowering parents is so important. We cannot separate the babies from the parents, and it improves outcome. And the parents has huge role in their place because the synapses and the dendritic arborization, which is the brain plasticity and the growth of the neurons, actually depends a lot on the love and the attachment that we get from the parents. So you can't go to the far away slide and read to your baby at home, like any term baby would have had this contact with the parents, unless you empower them while they are in the neonatal unit to do the same so they know what to do when they go home. And a Cochrane review showed that actually early developmental intervention programs provided post-hospital discharge to prevent motor and cognitive impairment in term infants made a difference up till 3 years of age. So early intervention, even from the neonatal unit, makes a difference. And there are two papers that I liked, which is this one because it talks about that parent behavior and moderate the relationship between neonatal pain and internalizing behavior, and that's what we see a lot in children, which is the children who are timid and afraid. And it was a controlled study, and it showed how these babies, there was a difference in their stress level, and it's a very good paper if you want to read it. And it was actually done in Israel, and they have seen babies to control between those who had kangaroo care and those who didn't. And this one actually from Colombia. This one from Colombia. This is the one that's from Israel, and they followed these children up for 7 times, and they showed that the respiratory system, heart rate, so even the cortisol level that they took from their mouth was maybe closer, but with stress, it was much higher in the control group who did not receive any kangaroo care, kangaroo mother care during their stay in hospital. And it was sustainable up till 10 years. So there was effect on cognitive function also. The reason I talked about the Colombian one as well, because they showed a very fast, quicker transmission of information between the brain and the muscle. And one of the things that we find is delayed in children born preterm is that they have late conduction, so their executive function become less, they need more time. So this was a non-invasive way in the Colombian study to show that they had faster connection as well between the 2 hemispheres. And this showed the stability on the physiology of the child. So in Queen Elizabeth, what we did a questionnaire on their family care, and we found that the most important thing for parents is consistency, and for staff is training, that they are not confident. And then Dr. Joyce O'Shea and the neonatal nurses decided to do an audit about kangaroo care over 15 days and through surveys, and they looked at 50 infants. So they had a median of 3. I'm not going to go into details, but I'll just highlight a few things. That there were 76% of babies held daily, and there was not much problems with those who held. The main problems was mom was sore in one, or the pressure was high in a line, and the temperature dropped, and some desaturated, and a lot of them were ventilated or on high support like vapotherm. So there were different types of support, and some were not on respiratory support, and some had central venous lines, some had peripheral venous lines or no lines, and the duration was average 1 to 2 hours, and that's actually what we see in most of the papers currently, although somebody wanted to more than 2 hours, one of the consultants with the blood did. We did also a questionnaire. I sent an email to all the neonatal consultants asking what baby would not allow kangaroo care. You will be surprised. It's only the ones who are very unstable on nitrate and on inotropes. That's the only thing that they came back. It's nothing to do with central lines or USC. The surgeons didn't come back to me except one surgeon, and a pediatric surgeon, and she said transanastomotic tube, because if it comes out, it's hard. But you'll find that there's not many that people said, oh, I wouldn't put my patient there. Although it's a nursing thing, but it's important to get medical staff on board so nobody can complain. So people always say, what can we do? But I always say, everyone does his bit, and we should say what we can do. And it's not about ticking a box, and it's not about measuring files. It's about the family. Thank you very much.